You might notice a similarity in last name to my co-presenter, and there might be some familiar resemblance. Dr. Alex Yang, credit cohort 8, working in primary care in Wally, so take it away.
So you guys didn't get Lawrence texting you telling you to show up to do a presentation? How do I change?
Oh, the big green, big green button.
Oh,
yeah.
So, okay. Yeah. So my project was team-based care at the Wally Urgent and Primary Care Center. So I'm a family physician at the Surrey Urgent and Primary Care Center, and our goal was to increase primary care capacity at our site. So when we initially started, people's family physician or primary care practitioner was booking around a month to 6 to 8 weeks out from a patient appointment. So it was really difficult for people that we were providing care with to get timely access. So that was our project. The aim statement was to increase our primary care capacity. We were pretty reasonable, so 2% by the end of the year. But to get started, I wanted to. Can I go backwards? So I wanted to introduce my team because quality improvement is a team sport, and I can't do this on my own. Family physicians, we've been working on our own siloed for forever right now, right? And our goal right now is to break these silos. So I wanted to introduce my team. So the gentleman doing the stretching, that's Peter Kent. He's one of our longitudinal care RNs. He's here today. Our class clown, the Jacqueline, she's in the clown costume. She's our nurse practitioner that I worked with. And Anissa is in the black. She's another longitudinal care RN that really helped with the creation of what we were doing. So you can see in this data point, it looks pretty good. So in this point in time where this data is collected, we actually had a 25% increase in our primary care visits. So how did we do that? We got our RNs to be kind of like practitioner extenders so that they could help with some of our chronic care visits and our follow-up with our patients. So we created a checklist with our team and trying to find which areas of where they were the weakest in, and which areas that they wanted to develop more. So we developed this checklist that we did at certain intervals so that we could identify where we could provide in-services for. So like every 3 or 4 months we would do this checklist, and then we'd see where their lowest scores were, and then we would do an in-service on that. And our goal was to create a strong area of knowledge for them to help support primary care with our patients. And one of the things that we really wanted to work on is helping to be proactive with chronic disease management. So we worked with systems ops to help pull data from our data panels to focus on chronic diseases. So with these things, these were built-in queries that are based off of like the physician support practice program, where you could work on chronic disease management. So you can hit the chronic disease, you can see your panel who has these diseases, and we could use that to be more proactive with our panel, because lots of times our mandate of our patient panels are very complex patients, chaotic patients, and it's really easy to lose track of them. So this way we could have someone proactively keeping an eye on our patients with chronic diseases and recall them. And then part of our process is spread. So most of the team members, or pretty much all the team members on my team that I introduced except Anissa are gone. They departed to other areas. And with that, hopefully they're bringing some form of spread to different places where they work. So Peter works now in a clinic in the Vancouver PCN, and he's sharing some of his ideas of RN-led visits to his clinic that he's working there. There's the Newton UPCC, so the other urgent primary care center in Surrey, and they're using some of our ideas to try to make their primary care teams more robust as well. And that's all. Thank you.